So I'm Kyla. As I stated earlier, I'm the Certified Peer Recovery Specialist. I'm filling in for Veronica to present this topic. So we're going to be discussing caring for justice-involved individuals. And I have no financial affiliations or conflicts of interest to disclose at this time. To start off, I want to talk about the three components of the justice system. We have law enforcement, which is our police officers, the court system, which is courts, and then the corrections, which is our jails and prisons. Fun fact, I was pulled over about 15 minutes ago, rushing from one meeting to the next. And I started thinking as I got pulled over, I got pulled over for having my phone in my hand. And I was like, we have a lot of patients that might not have a license because of fines, but they're driving because that's the alternative that they've chosen. And maybe it's their only option that they see. And something as little as having a phone in their hand could have a snowball effect in their life. So I didn't get a ticket, by the way. So also I want to talk about the flow. I'm going to give you guys a minute or two to kind of look at this. Okay, so now if someone would unmute if they're comfortable, what would be a reason that this would be important for us as healthcare professionals to understand the kind of ins and out of this and where our clients might be at?
It seems like it's a vicious cycle, if I understand the question
Yeah.
appropriately.
Yeah, so actually the next slide goes a little bit more into that cycle. Yeah, and there's not a wrong answer for this. But why might it be important to know that our client has court coming up in a month and they're looking at 5 years, right? What might that do to their psychological, the impact of that, right? Or maybe they need to taper, right? For our doctors that are on here, maybe understanding that they are going to be away. So maybe if they choose to taper because they're not able to get their medication. So understanding the ins and outs of that, also to collaborate care. I know we have a case manager on here, and sometimes like helping someone guide compliance with the criminal justice system, right? We have patients that they might have probation in a week, but they don't have their fines, but they come in and they present with some apathy and resistance, and they say they're not going to probation, right? Or we might have a patient that comes in saying that they're not going to communicate with their probation officer, but they're going to go to inpatient rehab. So having a collaboration with them and guiding them towards compliance, because we understand this is a vicious cycle. Thank you for saying that earlier, whoever said that. Is there anything else that this might be important for?
I would say long-term effects for the patient. I had a patient just yesterday that's been sober for the past couple of years and has some old charges that are about 8 or 9 years old, but completed a medical assistant program and got her first job, and they fired her 2 weeks later because one of the insurance companies did a background and they weren't able to keep her. So she relapsed. It was just too much, and she went and used, and very unfortunate, but the long-term effects of what goes on.
Yes, absolutely. Yeah, that's very unfortunate, and we see that a lot. Also, when people go into the system, talking to them about the risks of when you do come out, your tolerance, right, might be lower. The risk of overdosing might be more so when you get out. So having these conversations and kind of having a timeline. The next slide I'll go ahead and go to. This is kind of more like it. By the way, I drew all these cool things on Canva, and then when I tried to translate it to PowerPoint, it didn't show up. But anyways, if we look at this crime, like the light blue is where they enter the system, right? Then the yellow coming out of the system. But as we know, and as two of you guys stated, it's kind of it's not really linear. It's more of a circular motion, right? And a lot of times we see that revolving door, right? So we have the jails, rehabs, and homelessness. And this is a very vicious cycle. Something that's not on here is recovery courts, and that's formerly known as drug courts. So when someone's saying recovery courts, that's That's the old drug courts. And we know with substance use and that intersection of substance use in the criminal justice system, how hard it is to follow a program that doesn't allow for imperfection, right? That can be extremely challenging. Okay, next we have objectives. And it was funny when I was making the slide because it made me think of like the parenting, right? So even though they're different approaches, there's the same goal, right? So to be a productive member of society, right? So for the treatment objectives, we have rehabilitate, support, develop, validate, and allow for imperfection. Whereas the court objectives are restoration, dictate, control, punitive, and they demand compliance. So understanding that can be helpful in helping our clients as well. This part, which is my favorite part of the whole PowerPoint probably, is the slang and the culture. So why might this be important? Can anyone unmute and say why this could be important to know? Don't all go at once.
To know what your patients are talking about.
Yes.
There's some here I've never heard of.
Yeah. Okay. So if someone comes in and they say, yeah, my cellie, like that's roommate, right? Or the quad or the cell. So a quad is they're living amongst a lot of people in bunk beds in a big open room. Whereas a cell, might be them and their cellie roommate. Or maybe they say there's a lockdown. What's the difference in lockdown and the whole? So a lockdown is when the whole prison is on lockdown. So maybe someone was stabbed or maybe someone brought contraband inside. So they have like a lockdown, no movement lockdown. But if they say, I spent a lot of time in the hole, well, that's usually on an individual level, right? So they did something and they were in solitude for XYZ, however long it was. Shank, a weapon. JPay is a form of communication or the system of that and how people make payments to the courts. Prison purse, I'm not going to explain that, but I think you guys can figure that part out. One big one is we'll have patients that come in and say, I'm going to flatten my time. I can't do an 1129. We might be like, what does that even mean? Right? So if someone says they can't do an 1129, that's a misdemeanor probation, 11 months, 29 days, meaning that they don't do well on probation. If they flatten their time, they don't have probation, right? So they can flatten their time, say, you can go in for 3 months, flatten your time, or have a 2-year probation sentence. So they choose to flatten their time. Over on the culture, we have gel mentality. I work at a women's inpatient. Well, I'm an intern there. And we have a lot of, the workers will say, oh, this group has that gel mentality. Well, what does that mean exactly, right? So with the gel mentality, their way of surviving is to adapt, right? So their environment, they need to show no signs of vulnerability. That's weakness. So, and I've witnessed, and some of you guys might have family members or friends that, or maybe you've experienced incarceration, and when you see it, you could even change your whole tone just from being in that environment for a few weeks. So you could imagine what a few years would do. There's hierarchy in gangs, and that goes with a sense of entitlement. You might see a patient come in, and she goes into the quad, and one of the people that are higher up have that sense of entitlement and just take her things, right? Lack of empathy, unwritten rules. So unwritten rules could be trust no one. That's a big one. Don't talk. And that could translate when they come out on the outside, right? They don't trust us as healthcare professionals. They don't trust their family, don't trust their friends. And sometimes that's hard to get back. Bartering and trades, this could translate to selling drugs when on the outside, right? Tattooing and same gender sex, which we know increases the risk of HIV and Hep C and things like that. So just being aware of that. Also, that's kind of the culture. If you're really depressed and you're in that state, sometimes you'll do anything to feel something, right? So that might mean having sex with the same partner, even though that's not your preference. Also, institutionalization and psychological impact of that is really important to understand what that entails, and that victim helplessness mentality, which we'll talk about at a later slide. So why does this matter? I think we hit on a little bit of that. But understanding all of the challenges and barriers and roadblocks. Does anyone want to name a few of the unique challenges that one might face? I know that we had said, someone had mentioned earlier, like the long-term impact. What other impacts are there? What about family dynamics? That one's pretty big, right? Some of our patients go in and they lose everything. They come out and we know we know about housing, how hard it is right now. We have people that are on housing waiting lists for, a year and a half. Some counties aren't even taking applications, right? So imagine coming out and having nothing and there not being resources, right? I'm sure you guys have heard of the Maslow's hierarchy of needs. And I thought this graph was really neat. I'm not going to read all of the fine print, but essentially, people who are in the justice center or system have a higher way to climb, right? So there's it's just tougher for this population. Also finances, transportation, our clients that are in that revolving door, it's extremely challenging for them. So just making a mental note of that. Oh, I went the wrong way. All right, so how might patients present? So if we have a patient that is justice involved, sometimes they're living in that state of being where it's that flight, fight, fawn, and freeze response. And sometimes through things like complex trauma, they might not understand that they're in that state of being because that's their normal, right? So realizing that the trauma response that they're experiencing could make it harder to do therapy sessions or to even set a goal or to get a driver's license, right? Internalization. So there's this quote that I really like, and let me think about it so I don't mess it up. I'm not who I think I am. I'm not who you think I am. I am who I think you think I am. So if society is putting these labels on, criminals or saying they're a lost cause, imagine, looking into all of your family and friends and the disappointment that they see if you're looking at them and you have identified as this lost cause and society has deemed you as that. Imagine how someone might internalize that, and that might cause apathy, right? So sometimes apathy, what's hidden underneath that is ambivalence. The clients that come in and they're like, I don't care, right? Well, sometimes those are the clients that care the most. So just because they might be presenting one way doesn't mean that's how they actually feel. I thought this was kind of neat, this drawing or this little picture of a therapist or a healthcare professional working with someone that is experiencing a lot. And in the picture, you see everything's coming off really straight or not straight, but in a perfectly neat circle. But it's coming onto this client as scattered, right? So they're not able to be in a place of maybe even having a conversation at this point. All they can think about is, in a week, I'm looking at 5 years, right? So sometimes realizing that could cause that to a patient to not be able to comprehend what's being said to them. Also, prisoner of circumstance. I don't know if anyone's heard of that, but I really like that idea of someone who's in that prisoner of circumstance, that helplessness, that victim mentality. How can we work with them for them to be able to break free from that, right? Those patients that they can't see the light at the end of the tunnel. They can't even see a flicker here and there. Like it's just, they can't see it. So working with them through like motivational interviewing and some of these things I'm going to discuss at a later slide, but having that mentality instead of just saying, well, they don't care, right? That's just the way they want their life. And I have a quote. This is an example of someone that might be in that prisoner of circumstance. So it says, I've sold drugs my entire life. Now my probation officer wants me to get a job. No one will hire me. If I do get a job, I'll be surrounded by people doing drugs. I might as well just sell drugs. right? And maybe this person owes a lot of money and that's their only way that they can see it. So helping them get to a place of, wow, it sounds like you probably picked up some skills along the way of selling drugs. What kind of skills do you have, right? So using their strengths in a way that could be helpful and healthy in their life. Because even though they might have these strengths, it might be working against them, right? Some people are pretty good at selling drugs, right? So picking those strengths from them and using it in a way that's going to serve them can be really helpful. All right. So now I talked about how patients present, but now I want you guys to think of how you present to the patient, right? So checking our expectations, what are our biases? That's going to be really important too. Also, I wanted to mention there's a difference in understanding and letting things slide. So when we let things slide sometimes, because maybe with those patients with that revolving door, we might be doing a disservice to them by just letting things slide because we feel that they're in a helpless place, right? So a lot of these bullet points are from like a court perspective, but there also might be things that we expect from them on this list as well. So imagine coming out of jail and someone telling you to abstain immediately from the one comfort you know. A lot of times people are coping with substances and just asking someone to stay away from it. It's going to be a hard task. It's like taking a baby's passy, right? It's not, they're going to have an emotional reaction to that. And then start working now, TikTok, even though you don't have transportation, you don't have stable housing, you don't even know how to do a resume. You've never even had a job, but you need to start working now, right? Cut off all your friends and family, no hesitation. Maybe they don't have any support and we're asking them to cut off the one person that is an emotional comfort to them. Family concerns, ignore them. I've worked with some dads that have order of protections. They can't see their kids, and it's sad. And they just are like, oh well, like I fucked up. That's just the way it is. But helping someone, just giving them that emotional support of the family dynamics that happen through that. Also stop thinking like a criminal, even though this is how you've survived your entire life. A lot of times that can be really challenging. So look and see the expectations that we're putting on the clients can be helpful. So if you've never experienced substance use or justice involvement, there are exercises that could maybe increase empathy when you are working with someone. One example is to try taking something away. So an example would be caffeine. Maybe that is Starbucks for you. And if you do have a return to use, lock yourself in your room with no technology for the rest of the day. And just see how, what emotions come up for you. Oh. All right, so where do we begin? So we have different treatment models that we can use, a shift from punitive to supportive. Also, it's worth noting, sometimes abstinence isn't realistic for some of our patients, right? So understanding that, looking at multiple philosophies and not just sticking to one. We have motivational interviewing, which I mentioned earlier. This can be extremely helpful in helping our clients plant seeds, right? So the ORs, the open-ended affirmations, reflections, and summarizing can be extremely helpful with patients who are in that contemplative state of change or pre-contemplative. That can be a really useful technique. CBT. With CBT, there are certain situations where this might not be helpful to a client. I worked with someone who was looking at 10 years and we started writing down his thoughts, and I realized a lot of his thoughts were rational. His situation was just terrible. And so trying to reframe his thought didn't really work in that situation, right? So that's when like acceptance and commitment therapy could come into play. But with the CBT, this could be extremely helpful in looking at a return to use autopsy. What happened when you had the return to use? What was your thought, right? A lot of patients that we work with, they go straight from an emotion to a behavior. So it's, I get pissed off. Anger is usually a pretty big one. I get pissed off. So now I'm going to go use like the thought. They're not looking at the thought in between it. So that can be helpful CBT and for them to recognize what they are thinking and challenging core beliefs. Some of our behavior comes out of some negative core beliefs that we hold. So that can be really helpful in that as well. Neuroadaptation, this is helpful when we as practitioners understand the disease model. We understand how dopamine works, why it's not appealing to go to your kid's birthday party when you're using something as strong as methamphetamine, right? So understanding that can be extremely challenging or extremely helpful in their challenges that they're facing. Also trauma-informed care, understanding that they might be in that flight, fight, fawn, and freeze response. And this might be why we aren't seeing progression. Acceptance and commitment therapy. So with patients that have that inflexible thinking or patients that are extremely depressed or having anxiety, this model can be great for that and that unconditional self-acceptance. So moving from that kind of victim place to self-acceptance. And this can be helpful when we have a lot of patients that are struggling with guilt and shame. Then we have DBT. This can be helpful for emotional regulation and boundaries. Boundaries are huge. Also it's not just for borderline personality disorder. So this could be a really good model. In the next slide, I have two photos. I have the anger iceberg with a lot of our patients that are justice involved. Maybe they've been in for a while and, showing your emotions, is one of those unwritten rules. You don't show your emotions, right? And for a lot of patients, they've suppressed their emotions. So helping them identify what they're feeling. A lot of the emotions, it's just anger, sad, happy, right? So understanding what's underneath it. So maybe we have someone that, keeps getting in fights. Maybe it's from being rejected, or maybe it's guilt. Maybe they have some guilt and they act out in anger. So identifying what's underneath that can be helpful in emotional regulation, which could in turn help someone from that return to use. If we can catch it before you get to the return to use, that could change their whole life course. Also, I wanted to put this on here. I thought it was kind of neat, and I did pay to be able to share this professionally, but some Lindsay, I can't read the last name, but she made this emotion sensation wheel. I'm sure you guys all know or have seen the feelings wheel. Well, I thought this one was neat for patients that might not have the words or understand what's going on, but they can tell you the physical reactions that they're having. So I thought this was neat. I really liked this one, so I wanted to add that. So if someone is struggling finding words for their emotion, there are other ways to explore that. Case studies. Okay. I feel like I rambled on. Let's see. I'm going to try to leave like 15 minutes for everyone to share, have a group discussion. All right. So I'm not sure if you guys know, but the way they identify inmates, it's 8 numbers in the last name. So I tried to get a little creative and put, the inmate number. So for let me find it. Okay, the first client we have is a 38-year-old female. She's single, has a 7-year-old child, has no medical concerns, history of major depressive disorder and PTSD. She has a history of sexual abuse and intimate partner violence. Her diagnosis is OUD, STUD, and benzo use, all in remission. And in a few months, she is anticipating a 45-day sentence where she will spend 28 days in an inpatient rehab facility, or that's what she's assuming will happen. She comes to us asking for Sublocade because she was denied her medication the last time she went into incarceration. She was denied it, so she wants the Sublocade because she has that fear of withdrawing. She does come to us also with a concern of her ex-boyfriend. She, in her words, they're trauma bonded together. And he recently broke into her home and she doesn't feel safe. She said she cringes when he comes around, but they are still sexual together. So they have this sexual intimacy and out of fear, she also says she punishes herself sometimes when she does that. Or that in that act, she feels as if she's punishing herself. And so one of her things is she wanted an order of protection, but she's hesitant because an order of protection could mean that she could violate that, right? So if she gets an order of protection and violates it, that could violate her probation. She's on probation in different counties as well. And so she's very hesitant of that because that means more fines, more time, another violation if she doesn't stick to that. So I thought that was an interesting case because you can see how she needs an order of protection, wants that, but she has that fear because she knows if she screws up on her end that could have an effect and not be so well. But at the same time, she fears her safety. So that's kind of one of those things where she's on the fence about what to do and how to navigate that. The next patient, we have a 33-year-old Mel. He is in that revolving door. So he's experiencing homelessness, rehabs, incarceration, and he has a history of PTSD, major depressive disorder, generalized anxiety disorder, and ADHD. He is a high case management need patient. He lacks housing, needs dental, has food insecurities, pretty much all of the case management you can think of he needs. He is an IV user. He has pending charges. He falls off and falls on with us. So we might not see this patient for a few months and then they pop in, right? He has a mistrust in the system. So anytime we try to do behavioral health with this patient, he is not open to it. And he says from an early age, he was forced to be medicated and he has a lot of resentment and anger towards therapists. He's extremely resistant and apathetic. He has a probation appointment in a week. He says that he is not going to his probation. He owes $35, but regardless, he said if he had the money, he wouldn't spend it there. And he's highly intelligent and he has an extremely high ACEs score. All right, next we have 27-year-old female, OUD in remission, no mental health or medical concerns, a very low ACEs. Didn't start using until around 22, caught some legal charges and ended up getting doing pharmacotherapy, and she is on buprenorphine, was forced off of her buprenorphine by her probation officer because she signed something that in order for her to be granted diversion, she had to complete her buprenorphine program. And as we know, this isn't a program that we complete necessarily. So there's she was forced off of her medication, and after 6 months of abstinence, she overdosed. She ended up violating her probation, lost custody of her kid, and now she has turned to methamphetamines and is looking at a 5-year sentence, and that's coming up in a few months. Then next we have 67-year-old male. He has AUD, OUD in remission, no medical or mental health diagnoses. He's highly intelligent and applying for jobs. He recently was divorced and he is struggling financially. Worked with him a few times and then found out he has a harassment charge that is a huge barrier, and that is why he has not been able to gain employment. Yeah, so that's it. If you guys want to kind of think of what would you do? Where would you start with these patients? And then maybe share. I think I guess I ran through it kind of quick, but we can just have a group discussion. And if anyone has case studies to bring or wants to talk about one of these cases, we can. Oh. I'll go ahead and there's my references. And here's the slide.
So before we go ahead and talk about the cases, we did have one additional person join us. Valerie, if you wouldn't care to unmute, just briefly introduce us, or introduce yourself to us.
Yes, I'd be happy to. My name's Dr. Valerie Boaz. I'm a retired physician and certainly appreciate all the information that's been shared.
Thank you very much for joining us. As you were saying, Kyle, why don't you go back to the case slide just so we can see those some of those names that you talked about. I would say a particular something that resonated with me with patient number 1, Miss Jones there, would probably be that I've been in this situation before. Where somebody has some kind of impending incarceration, and I have them on buprenorphine as an outpatient prescription, and we're wondering what to do. Sublocade is, I guess, an idea that could, probably work temporarily. It probably wouldn't work for more than 30 days or so. So this is a challenge. There's, in my experience, there's pretty varying acceptance of buprenorphine and other medications for opioid use disorder amongst jails. The prison system does seem to be a little more accepting, is my personal experience. In fact, I've seen several patients in the hospital who are essentially actively being put on buprenorphine while they're in the prison system. So that's been encouraging to see. But as far as jails, I've seen really varying acceptance based jail to jail, county to county, on what's going on and what our protocol would be for buprenorphine. This puts providers in a hard situation because, from a medical standpoint, from a guideline standpoint, there's really no reason to change the therapy. I'm saying continue it. Also, unfortunately, I think it leads to some of the patients kind of getting a case of, well, I'll just do whatever I want, right? Because I'm going to jail anyway, right? So, I've heard them say before, well, it doesn't matter what I do. I could go out and, use other substances or essentially, go all in right before I go to jail, which is not what we want to see. And then there's the aspect of withdrawal management and having to manage that upon incarceration that further complicates things. So it's not a good situation to be in, for sure, but it is absolutely one that exists.
Yeah, absolutely. And yeah, we are seeing that the buprenorphine is more accepted in jails, but like you said, we have some patients that are somehow are on it, and then others aren't able to get it. So yeah, it's scary for a patient not knowing, right? That's kind of their safety blanket, and they don't know. So they might run just out of fear of the unknown and catch another charge, and then more fees, more fines, all that. So yeah. Yep. Anyone else?
Other comments, questions on Kyla's either presentation or on one of these cases, which I thought were really good. Something else I would mention too, just looking at the presentation, would be that this is a vicious cycle. All right, I saw that some of those things, some of your diagrams are good, and that there were things going in circles, and also that this system is pretty darn complicated. And I admit I do not understand 100% of what's going on with some of these patients sometimes. As in, there's so many different the days that they're going to court, and what exactly all the hearings are, unless you've been through it yourself or have somebody who is going through it closely. It can be hard to keep up with what's going on, which does actually help you. If you're able to understand that, I think you're able to help the patient a lot better if you're able to, for example, work with their probation officer, parole officer, whatever it may be. I think that can be really helpful for the patient, and kind of getting them where they need to go.
Yeah, and imagine being a patient and struggling with that intersection of substance use, and you're actively using, and you're having someone tell you, things that aren't really clicking, and maybe it's going above your head and then you don't know how to relay that. Yeah, we've had patients that some of their story of what they're saying, it doesn't really make sense of their court dates and what's going on with them. So yeah, just understanding that they might be in a place of not really able to understand what's going on.
Kyla, I'm thinking of our patient who was pregnant and incarcerated, and all the complications with that, and getting care for her, having to go back and forth to the jail, and just how much I feel like it complicated her pregnancy, but also just her psychiatric health. She was having a really hard time. Yeah. I don't know if you know all the details or want to talk about that any, but that comes to mind for me.
Yeah, that's definitely big. And there's been people who have been incarcerated because they're on buprenorphine being pregnant, and they didn't have a valid prescription. And there was, I think it was Gatlinburg, someone had a baby on the street to avoid the legal repercussions of having a child with things in your system. So being pregnant is definitely another thing added on.
Yeah, I don't know if it was that patient or maybe a different patient that we had, but it was a pregnant female that we were taking care of, and we ran into that issue. The jail would bring her to substance use appointments with us while she was pregnant. But I guess it was their policy that as soon as the patient delivered, they no longer fell under that protection, and they stopped bringing her to appointments.
Yeah.
So they essentially just kind of threw them out to the wind and said, you're going to withdraw in jail now as a result of of no longer being pregnant.
Yeah.
So I guess it is a step forward in the fact that they did have some protections and a program in place for her, given that she was pregnant, but didn't continue that after.
Yeah. And I don't know the name, but I think you were speaking, but you were on mute. It's you work at Alliance. Is it Melissa?
It's Suzanne.
It's
Okay.
Suzanne. I know that's confusing. I'm sorry. I was talking to the lady that's training me. I wouldn't.
Oh, okay.
I mean,
I was
I'm
like,
training. I'm sorry.
no,
I'm trying to do too many things at once.
Susan, I heard it right. So
I did want to make a comment though, about a barrier that I recently had with somebody that has struggled in the legal system for multiple years. And this is something that I've battled with several times with patients, is patients that end up on the sex offender registry. That is a huge, there are so many barriers with that, with getting the treatment, obviously living situations, sober living environments, that creates a huge problem. I just discharged someone the other day that we had, I mean, it just takes so much manpower, which is very unfortunate for these patients. They're trying to get well, and some of them end up on the registry for prostitution to feed their substance use issue. And so that's kind of a huge barrier when we were talking about legal situations, that just red flag in my head, because it's always a struggle. I've had a lot more recently. But yeah, just finding placement and housing, all the things that come with that. So
yeah, the cycle.
Yeah, I've absolutely had that same issue before in the psychiatric hospital. Finding somebody placement when they're on the sex offender list is just next to impossible. That is definitely a challenge.
and we do have a local treatment center here for uninsured patients, well, insured and uninsured, that has a couple of beds, but it's literally a couple. I don't know how many it is total, but it's not many at all. So whenever we have a patient that comes through the crisis center, comes for detox or mental health or whatever, that's requiring or wanting to go to residential treatment, we're kind of backed in a corner. It's often very hard to get them somewhere. And we can get them on a list, but turning somebody loose that doesn't have a good environment to go back to. I mean, y'all probably all know this, and then waiting on an SO bed that may not come open for a month, 2 months. I mean, likely them staying sober and trying to get it together is not feasible. So anyway, I did want to mention that. So I'm sorry, I wasn't talking about whatever you asked. I was not answering to
Well,
that.
I'm glad that you shared regardless, because that is great. And I think you made a good point that the act was, to prostitution of the substance that they were wanting, and how something like that could land you on that. Because some people might not know that it could be something like that. And so I think that's important to reduce the stigma of it.
Yeah, for sure. And I just wish that we had more resources and, for those patients on the registry, because and we're in Memphis, so huge spot here, over in West Tennessee. And it's like, how do we not have more resources for people? It's challenging for sure.
Absolutely. All right, we got about
Other
10.
thoughts, comments, questions?
I'm gonna start calling on y'all. Shannon, what you got?
One
I actually got
thing.
some. Oh.
Oh.
Go ahead, Blake.
No, you go ahead. I don't have anything really. Mine was an emotional comment. It's not academic at all.
Well, we like the emotional ones better, Blake.
Well, the real question is, how do you overcome? Like, I need some sunshine after this talk, and it seems like it's such a hopeless thing, and like being trapped in so many ways. Whether some of these people we talked about, whether they're trapped in the legal situation, or whether they're trapped in the really unenviable position of being addicted to substances and having that as something that, if you've got $100, you've got something that you can rely on to make you feel better for a
Yeah.
short time, and the big trap of that. But we know that some people do have success, and I know all of us here listening to this are thinking about family discussions around the dinner table about, relatives of ours who've been in and out of jail, and the whole concept about being lost causes and have boundaries, and those are sorts of things emotionally that do come up.
Yeah.
And I guess the real question is, like, for anybody with any kind of challenges, which is all of us, how do you come up with the resources that you need? And I'm not just talking about the physical resources, although they're huge, but how do you come up with the resources to address the issues that you're facing as far as the issues with the substance abuse? And of course, being incarcerated, I've not worked in the prison system, but my home state of Florida is full of prisons, lots of incarcerated people, and lots of substance abuse. If you believe what you read in the newspaper, tons. It's like the prison system is awash in drugs.
Yeah.
And it's almost like that there is not a lot of inclination or resources to treat some of these victims that are incarcerated. And it gives you this hopeless sense for these people. And then I know, like, when you go to places where they're clerks, and after some people that have suffered some of these fates, they're lucky to have these jobs at Dollar Tree, or they're the people checking you out in the grocery store. They're the people that make society work because of what they do. We need them. They don't get paid much at all. They're
Yeah.
right on the edge. And some people do find the wherewithal um, to try to have the improved life, and that is the bit of sunshine, but it's a really unenviable situation. And my comment in the chat about when someone's looking at jail time or looking at court, and that the risk of suicide, because we all know people that had these pending things, and they passed away, unfortunately. It's a hard situation. It's a really hard situation. I'll be quiet now because none of this is, but anyway.
Thank you, Blake. And I was looking at the chat. I'm sorry that I missed that comment, because that's huge. And I think for some patients that it is a hopeless place, and having, I think I'd mentioned earlier, just a little flicker of light, because it's in everyone, right? It's there, and just being able to bring that out, and you know, the support groups and the recovery communities, these are huge, and it can really do amazing things when you see what communities can do. Maybe there aren't resources, but there's a community out there, right? And so I think when we don't have resources, and whenever we have patients in these hopeless places, it's looking at the social aspect and what can we add. If we can't add, you know, stable housing, we can't add transportation, we can't add these things, what can we add? Because there's always good that we can add in the world, right? And sometimes that's smiling at someone and just treating them human, and not like they're less than, having conversations and not pitying people, and just helping them see that little spark.
I think there's reason for hope from a few standpoints. One is that we've come a long way with this, right? We've come all the way from war on drugs, you know, from absolute criminalization to the development of, you know, drug courts or recovery courts. And those have come a long way. I think those have done good for a lot of people. Treatment is expensive. Hopefully, I would be hoping that, you know, any treatment dollars invested into treatment would be paying benefits down the road and keeping people out of incarceration, because that's even more expensive. So I think that's one, you know, possible source of funds, and hopefully, and I believe that the drug court system has been successful in that, in reducing the amount of dollars spent overall by focusing on treatment and prevention rather than on just incarceration, kind of locking people up and throwing away the key. So I think that's one thing to be positive about. Another is kind of the ethics of it too. That, you know, this can be kind of a form of compelled treatment, right? You know, some people will liken it to contingency management, but really it's more of a, you know, do or else, right? Sometimes the, you know, treatment stipulation is that you will do this or else, you know, you could be incarcerated or something like that. And hopefully it ends up working out for everybody. But it is sort of, you know, ethically, we are balancing somebody's autonomy, right? Their ability to make decisions for themselves and their right to do that with what is best for them, and what's going to be best for society. So it's a complicated arrangement and not an easy decision to make, especially when we're making decisions about large groups of people and not individuals.
Yeah, thanks for bringing light on the macro side of it. All right, we got 3 minutes, or maybe, no, let's say 3. Shannon, you want to close us out? What you got?
I was going to go like the stuff that I see out on the, you know, a counseling perspective. It's like the caveats of like hyper awareness, transitioning into society without, you know, the commissary, with the, you know, the monetary system that they have and what we have, the freedoms of having $1 and being able to go to the liquor store or go get some gas station weed or whatever. So that seems to be one of the things that I'm coming across as a therapist, and trying to help them transition in from that incarceration to society.
Yeah, the lingering effects of all of that culture that it entails, it could have lasting impact. But yeah, I like that you mentioned, you know, when they do have some money, like they get to spend it on, they're not limited in what they can spend it on, right? But sometimes that might work against them, in having that freedom.
All right, well, I think we are about running close to time here, so I'll go ahead and call it. Rick Wallace has been kind enough to put some great articles in the chat, so feel free to check those out, and get those checked out before you go. We'll be back in 2 weeks. I believe Melissa just posted we'll be talking about pregnancy and parenting with Dr. Troxler and Veronica Vann, right? So thank you all very much for joining us, and we will see you again in 2 weeks.
Bye, guys.
Thank you all.